Welcome everyone to our office. My name is Akash Magoon. I'm one of the co-founders and the CEO at Adonis. Adonis is a company I started with my brother Aman, and we work at the intersection of AI and revenue cycle. But tonight's not about us. Tonight's about hearing from our three esteemed guests who are executives at three different academic medical centers. First up, we have Richard Silveria. Rich is the Chief Financial Officer of Ohio State University, a hospital that I think does north of $7 billion in revenue. Rich has had an impressive career transforming multiple health systems, including a CFO role at Boston Medical Center, University of Chicago, and Cape Cod. Rich, please tell us about your journey and what led you to your recent new role at Ohio State.
Well, it's great to be here, folks. I hope this is a conversation. Look, I have a pretty circuitous route to a CFO. I was a biology and chemistry major. Okay. And I was thinking about going into medicine. I did a practicum. They didn't call it an internship as an undergrad. And I decided, I had two sisters that were nurses. I was good at chemistry, biology, and I didn't think I could do the patient care. So I went for an MBA. I did a minor in IT. So my first 7 years in healthcare were in IT and implementing systems. And then from there, got an MBA and moved into the revenue functions, cost report, managed care, revenue cycle. Ran a big swath of the shared services functions for Partners Healthcare for 12 years. My first CFO role was at a safety net, which is Boston Medical Center, U Chicago. Did a short gig at Cape, and wanted to get back into academic medicine, and took the role at Ohio. So great to be here tonight.
Yeah, thank you. Thank you. Hey, do you mind just setting the stage for the audience around what an academic medical center is and why that's unique compared to other places that you've worked at?
Well, I've worked in both environments, community hospitals and academics. The academics, they call it the tripartite mission. My colleagues can certainly speak about it, but it's teaching, it's research, and it's the application of that in medicine. So you have a convergence, and hopefully you talk about bench to bedside or innovation to bedside. It's an incubator. It's also an expensive way to do medicine, but you have things like at Mass General, we had Embrel, you get a $500 million kind of royalty on that. So it's really an exciting place to work. It's maybe slow in terms of consensus. It's a lot of kind of intellectual freedom and discovery, and that permeates kind of the entire organization and every one of them I've been in. But it's a blast. It can be frustrating. It can be everything. But you're really rubbing elbows with people that are on the cutting edge of discovery, and like CAR T medicine, which was kind of my other colleague, Alvin can speak to more about the science of it. But the mRNA was a kind of a COVID and other things kind of hung off that technology, which started, in a number of academic medical centers, but Harvard and Mass General and Brigham were part of that.
Thank you.
Yeah.
Next up, we have Charlene Seidman. Charlene is the Senior Vice President of Revenue Cycle at Yale New Haven Health System, where I believe you spent north of a decade building and scaling revenue cycle. Could you share more about your journey in the organization and why you stuck around for over a decade to continue helping the organization scale?
Sure. So I first joined Yale New Haven in 1997. So I started with the physician group. And when we talk about academic medical centers and academic medicine, what Rich said is correct. It's a lot of consensus building. It's a lot of fun. There's a lot of challenges, but it's very, very complicated, and much more complicated than anyone ever thought it would be or should be, probably. So I started my journey at the School of Medicine, and similar to Rich, I started in healthcare IT, implementing rev cycle systems. And then when we put together a team to implement Epic, which was about 15 years ago, we went live. We've been on the system for 13 years now. I joined the Epic team, so I jumped into our ITS group. And at the conclusion, I moved into an operational role. So I've been doing this job leading revenue cycle for Yale New Haven Health for 10 years. And I'd say that the biggest evolution of my journey has been from implementing systems and looking at the transactions that are really, really dependent in revenue cycle, but moving into leadership and honing leadership skills, which I find the most fascinating and the most rewarding, and something that I have a passion for, as long as our patient financial experience. So My journey has evolved a little bit, but RevCycle has received so much spotlight since COVID. Everyone woke up and realized, wow, revenue cycle is really important for hospitals and health systems. What's going on in there? And so it's been great. The last 4 or 5 years, I think, have been really, really special.
Thank you. And last up, we have Alvin Liu. Alvin has had a illustrious career, and a few of his noteworthy roles include being the chair of the Artificial Intelligence Council at Johns Hopkins Hospital, as well as the founding director of Hopkins Ophthalmology Center. I've been lucky enough to meet many AI experts in my career building companies, and also meeting many world-renowned doctors. But I can't say I've actually met both of those two people in one person. Alvin, please tell us more about your journey and how you got to where you are today.
Thank you for that very kind introduction. So my name is Alvin Liu. I did most of my clinical training at Johns Hopkins, and I stayed on as faculty. I'm still a practicing retinal surgeon, but at Johns Hopkins, I spent the majority of my time in artificial intelligence, AI, in 3 different ways. Number one, as Akash mentioned, I have the honor of running an AI research center that was made possible by a very generous donation of $10 million. The second bucket is I've been very involved in the implementation of AI across the health system, both in the clinical and operational domain. For example, autonomous AI for diabetic retinopathy screening, and also Gen AI for revenue cycle management. And the third hat in terms of AI that I wear at Johns Hopkins is an AI governance. So roughly a year ago, leadership decided that we needed a more centralized structure to deal with AI, specifically to deploy AI in a responsible manner. So right now, we have an 8-person team, which has purview over all things AI related across the health system. And I'm part of the 8 people.
Thank you. So today we're going to learn from our 3 guests about what it means to build and scale AI within a hospital system, how you adopt it, how you measure it, and how you bring it into real-world operations. I thought it was important to kick off this discussion with hopefully baselining the group with what AI actually means. I know we all have heard the buzzword throughout different areas of our life, and I'll hopefully share a good definition, but Alvin, I'd love for you to give your perspective as well. From my perspective, AI has been a quiet part of our lives for many years. AI is what's used to generate the next song recommendation for you on Spotify, or maybe even recommend a shirt when you're looking to shop online. But ultimately, AI V1 has been really good at identifying and making a recommendation. But ultimately, the decision is made on you as an individual. AI V2, or why we keep hearing about AI now, is that there's a new advancement in AI called agentic AI. And that's where AI has the agency to make decisions for you. And so instead of just recommending you a shirt, you can have AI, understand that you want a shirt, but go through all the websites, figure out the vendor, identify the color, look at the shirt that might fall within your budget, place the order, follow the tracking, and make sure it arrives on time. And so that V2 of AI of completing the several steps needed to put a full act together is why I'm particularly excited about AI. But Alvin, I'm curious to learn more about how you would define AI, and then go from there.
Sure. So I'm happy to provide a little bit more context and then link it back to the topic of today's discussion, which is revenue cycle management. So the concept of AI has been around for decades. Essentially, it's our attempt to train a machine to act and feel like a human. Very general term. We've been going at this for decades. And then machine learning is a subtype of AI where we train these systems with a large amount of data, and hopefully it will learn from this large amount of data to be able to make predictions. And deep learning is a subtype of machine learning, which is what we're talking about today. So deep learning is very good at two things. One is what we call computer vision, which is image or video analysis. So for those who have Tesla, the self-driving technology is deep learning, is computer vision, just understanding visual information. And the second thing that deep learning is very good at is understanding human language. So the large language models that we are familiar with is a type of deep learning. And also, what's really special about large language models and generative AI is that it can generate new information. So it can generate new text, for example, for large language model. It can certainly generate new videos and images and whatnot. So in 2025, when people use the word AI, both within medicine and outside of medicine, for the most part, we're really talking about deep learning. And why does that matter for what we talk about today? So today we're talking about healthcare. It's a large industry. We spend $4 trillion per year in healthcare, and a lot of it is paperwork. For those who are operators, understand that there are a lot of processes in healthcare that are very repetitive, very time consuming. So, and RCM is an example of such processes. And for a long time, we have been trying to automate these processes, right? And the term is robotic process automation. So the name implies we have a lot of these robotic processes. We want to automate them. However, before the rise of deep learning, the way we've been doing it, it's very old-fashioned. So we hand design rules and teach machines how to do certain things. So a good example will be decision trees. The problem with RPA when it comes to operations and specifically RCM, it's threefold. Number one, when the process becomes more complicated, it actually also takes a lot of effort just to design these rules to begin with. The second drawback is they are very rigid and they always fail at edge cases. And number three, especially we are dealing with processes that involve electronic health record, these RPA processes cannot deal with unstructured data. Unstructured data meaning free text. So of course you can imagine a lot of things we do in electronic health record is free text or type a note. So basically RPA doesn't really work for RCM. With the rise of Gen AI, specifically tools and products that are based on large language models, we're really solving this issue. Number one, it's highly adaptable, meaning it can really solve a lot of edge cases with some level of reasoning and intelligence. And the second advantage is that it can understand context, free text in electronic health record, which we'll dive a little bit more into.
Thank you. That was a very detailed explanation, and I can see the audience locked in on you as you were explaining that, so I think it was really resonant with the group. Charlene, in your opening statement, you mentioned that revenue cycle has become really important, especially during the post-pandemic world. Can you help us contextualize why revenue cycle is so important right now, why AI is important, and maybe touch on labor shortages, cost savings, reimbursement pressures, and everything else that keeps you up at night?
Settle in, everyone. We're going to be here a while. Yeah, so it has always been important, but what the pandemic did was made everyone else aware how important it was, I think. So, where do you want me to go first? That's crazy. There's so many pressures right now that are facing us that we are trying to contend with. The headwinds with reimbursement and the decline in reimbursement for services has been a major challenge for us. There's still so many things that are undecided coming down from the federal government, which are going to end up translating into state and local levels as well. Big challenges with how do we afford to provide services and support our clinical mission on the administrative side. Because as Alvin was talking about, the burden of these transactions is so great. There are labor shortages. The cost of labor has been increasing for us. And so we're trying to find solutions with AI, RPA. I wish it was more advanced. I feel like it's been really, really slow, but we've been focused for maybe like 6 or 7 years now on coming up with ways to eliminate some of our repetitive tasks and as a vacancy occurs, not replace that, use bots. The biggest use case is probably our dependency on transactions with insurance companies. And so if you think about, we're all patients, and when you come to have a service, all of the transactions to get paid for those services, if you're insured, go through insurance companies. And then starts the entire process from the front, middle, and end. And revenue cycle, we're dependent on insurance companies. So we focus a lot on those interactions.
Rich, anything else you'd add about the why now in terms of AI and revenue cycle and why it's top of mind for you and your colleagues?
Well, a few things. I think society is saying they cannot afford the current structure. right? So, and I don't, how many will raise their hand? Medicare is going to raise their rates and going to make things right for us, or Medicaid. I don't think that's going to happen, right? And so we have to try to optimize our liquidity and get paid for the clinical mission. We have to decrease our reliance on labor. Is the healthcare is both a labor and capital intensive business. So if rates are going to be going down and there's relentless pressure on it, you need to think about, how do I get more efficient? How can I liquidate my receivable at the highest percent that I can? When you think about a good performing or a range of performance and denials is 2 to 4% of your revenue. 2 to 4% of $7 billion. It's a few bucks. The other thing I would say is the current process is just unsustainable. There's just too many rules. It varies by payer, it varies by plan, it varies by employer within plan. And so how can you understand the rules? And when they use CARC codes or ROC codes and they use standard data in various and in different ways, and you're dealing with clerical type staff on both sides of that transaction, we need automation, and we need to be able to ingest and understand that information in a way that you can have a meaningful conversation with constituents like the government or payers or your boss or whatever. If things aren't going well in revenue cycle, you have a high cost. But if all of a sudden your AR is aging, you have to throw more reserve at that. So what used to be $1 is now 70 cents. So why you're getting squeezed from the top and the bottom. So revenue cycle is probably the most critical function. No offense to anyone else that does anything in finance. It really is. And you got to get a good deal, but you got to liquidate it. And I just think it's the one rule, then 2 rules, and then 3 rules. But 3 rules is not like 7 million rules that are out there right now, and it's unsustainable. So that's why I think it's time. It's beyond its time.
Yeah. Rich, I know you've built a playbook of what revenue cycle should look like across the various organizations that you've led. What do you see currently as the biggest opportunities to apply automation across the revenue cycle to optimize for the labor challenges that you mentioned, as well as the cost issues as well?
I'll try to do this articulately. I'll probably do 3 parts to this. One is, what I sent the payer, is that what I got back? So when you think about, you send a claim, it goes through a pre-processor, and this person is eligible or not? Is this provider participating, they call it PAR, or not? And then once you confirm that, you'll say, what are the rates for this participating provider? And then what are the benefits pursuant to those rates? But before that, it goes into something like a code write. So you might send 11 lines, and they're going to bundle it into 7 lines. And then they remit back an entire claim that's 7 lines. So can we have some data that would say, hey, you sent 11, you got 7 back, or you send claims multiple times. So it's a huge big data issue. So one is, the 837 that went out, is that what came back on the 837? And tell me about a claim level denial or a line level denial. Then talk to me about the data about the data. So you might have a payer that says, this is non-covered. Well, what they really mean is, well, it's part of a DRG, so the DRG, it's not covered because it's part of the DRG. Another might say, well, that's not covered pursuant to their benefits. So you might ingest that data as a denial when it's really contractual. And when a reimbursement person will look at that dollar and say, well, there's some liquidity in that, and they're going to put some kind of reserve factor on it, when in fact it should be 0. And it shouldn't go into a denial queue and have anyone work it. So you almost have to have a Rosetta Stone where you can assimilate the data across payers, where they can say, look, I'm going to convert the various language and then ingest the data operationally, but also kick it back analytically in a common form. And I guess the other thing would be, is just not just that metadata, the data about the data, so you can, but can you crawl through the AR? Because about 85%, 90% of your claims get paid within 90 days. It's the buildup of the 10 to 15%. And then you run projects and you have SWAT teams. So why can't we invest in something like a Google that will crawl through the data and look for these CPT codes or these CARC codes? You have to ingest the data as presented from the payer, because it comes in and it goes to an ETL process, and you'll say this CARC code equals this kind of epic speak adjustment code, which is kind of nuanced by every entity. So every entity has a different code that it maps to. You have to get back to the source data. And then, so if you have that appended to the line or the claim, you can imagine almost a Google type utility and say, these things, stratify your AR below, $5,000 or between these things, and think about how whether you have a human or a bot or something like that. But you need to be able to real time, be able to segment your AR and think about your capacity either from human beings or machines to be able to convert that into cash. And I know that you're also focusing on which things typically get paid. Don't waste your time on the dead. Focus on the living, right? But you ultimately want to say, well, these things really shouldn't die. And you want to go to the payers and say, this is not right. I billed it as a 99214 and you paid me a 99211. So it's like, what did I give you and what did you give me back? And let's face it, it's a hard job. You get like another dump truck of claims coming in every day, and I could go fight on these 3 lines on this claim. And whether I'm working on a $1 billion claim or a $100 claim, it's the same frustration dealing with the payer. So we got to take the friction out of this. When you think about the costs and the complexity, there's not one kid getting immunized, not one indigent patient getting screened for cancer. It's a waste. So can we get that? And when you think about our contracts with payers, we have to write terms that say, you have to allow automation. If a machine is calling, you can't hang up on them. You have to expose your rules so my AI can understand the role at the time when I need an authorization for that drug or that service. So in a Six Sigma, I'll end it here. In a Six Sigma sense, revenue cycle is pure chaos.
And Rich, do you have contracts today where you've negotiated in like AI capabilities to?
Just starting to. When I was at Partners, we had performance and things like that, but we didn't have the capability to understand it. You're talking to people and they're trying to describe what's going on, and there's like this myriad of and it's really pattern recognition. So you really need to know. Lots of times you understand that a policy change because you're seeing denials or you're seeing them pay things at a discount, 100%, then 25% or whatever. And until you see that, many times you'll find it on the web in some kind of, small, you can't ingest the information. So I'll let my other colleagues speak, but I think that's the current state. So some of it we're pushing on it now. We're in negotiations with Cigna and United, and I've made my VP of managed care say, you make sure you put that in the language. And, but we need the tool. And I think we're in this room, you kind of have the innovator's dilemma, right? Well, tell me where you've done it before, right? We're on the cutting edge here. So I'll end it there.
Thank you.
Yeah.
Charlene, Rich spoke a lot about the challenges that he has monitoring and managing underpayments with insurers and downcoding and line level issues. How do you think about managing the changing goalposts of the payers, and how have you thought about automation within Yale?
I think maybe what I'll do, Rich spoke a lot about the 835, 837 CART codes, and maybe what I'll do is I'll bring into the upfront process and the
Please.
front end. So the insurance companies are designing plans with employers. Those plans often have high cost shares that are the responsibility of the patient. When we collect our payment, the allowed amount from the insurance companies, there's a high percentage of that is dependent on the patient paying. So you might think that you have great rates, but if you're not actually collecting the patient cost shares and working through denials, then you're actually collecting a lot less than you should be. For patients to understand their plan, it's so complicated. Most people don't understand, and some of us are experts in healthcare, and we don't understand it as well. What do you mean I have a cost share? What's my deductible? What's my co-insurance? And then how do I get a estimate up front to know what I could potentially be responsible for at the end? We need to do a much better job with understanding that, developing a really good price estimate for a patient, because we have implemented solutions around automation, AI, to collect or produce a really good price estimate for the patient. And we've actually shown that the more often you're talking to a patient and communicating what that amount is up front, the more likely they are to pay it. Even if they don't pay it up front and say, okay, I'm going to wait until I actually have a procedure or a radiology exam, I'll pay it later. They're more likely to pay it if you can produce a good amount of what they can expect.
Thank you. Alvin, you have the unique kind of vantage point within your organization to think about how AI can be applied across the business revenue cycle, but every other, area of a hospital operation as well. How do you think about communicating the value to various stakeholders that you have and moving at the pace of, how AI is moving so quickly?
I think Gen AI in general is a very exciting technology. The pie in the sky is really having an AI doctor, like an AI program that can replace me. That's not even sci-fi. It's possible in certain contexts. So I think in the media, we hear about Gen AI and you hear about the sexy things, right? The AI doctor, which is true. But however, I personally feel if we are looking at the next 3 to 5 years, the most important and practical application of Gen AI really is in revenue cycle management. It may not sound as sexy, but ultimately it's directly linked to a dollar sign. And there's a saying in like academic medical center, which is no margin, no mission, right? So we need to have a margin to do what we think is meaningful and important. So I do think that Gen AI application in RCM is very, very important. And if I have to pick one, that is the most important application in medicine in 2025 for the next 3 years. So with that in mind, I do think that the technology is getting more mature. With a caveat that if you look at the market right now, a lot of companies say that they do AI, especially even companies will say they're doing AI for RCM. But when you actually dig deeper into tech, it's just good old RPA. Nothing has changed. Not a lot of companies can or have taken advantage of the true power of Gen AI, which I explained. And Adonis is one of them. I think they're doing a great job. It's the real AI tech, in 2025. So I'm very excited to see what Adonis is going to do in the future. And I think it will also be helpful to give a few specific examples across how Gen AI has been across RCM that I've seen that has really generated real ROI. And very briefly speaking, we can think about RCM in 3 different stages: front end, mid cycle, and back end. Front end, essentially, you go to see your doctor. Then we have to verify that you're eligible to see a doctor and you're eligible to get certain treatment. And oftentimes it requires prior authorization. Essentially, a doctor will need to prove to your medical insurance company that it's medically necessary to give you that treatment. The way it's done right now is really antiquated. Essentially, you have a human look at the chart. This is your log into the payer's portal, figure out the rules that apply to this particular patient, look at the chart, and then manually pull all the relevant documentation to submit to the portal. Right now with Gen AI will look at the payer portal, understand the rules, look at the electronic health record, understand which documents are relevant, and then suggest to the human, these are documents that you need to upload in a matter of seconds, if not minutes, to prove eligibility. So that's the front end. Mid-cycle means, after you see your doctor, the doctor needs to document something, right? Ms. Smith today saw me, she has some, heartburn, and these are the diagnoses, and that's what I did. So that's very much documentation heavy. And in mid-cycle, the 2 very important areas, which is clinical documentation integrity, meaning we want to make sure that doctors document correctly to bill at the appropriate level. And the second part is coding. Once you verify your documentation is correct, then you have to submit that claim, right, to an insurance. Again, Gen AI can definitely help with fixing the documents in a way that's efficient, capturing information that was discussed but not documented initially, and also code appropriately. And for the most part, I think doctors undercode. So now we can actually ensure that doctors and hospitals get paid legally appropriately at the right level. And the third stage is back end, which is claims denial. So you submit a claim, the payer say, no, I'm not going to pay you. And then it's a very laborious process where you may get a lot of claims. Sometimes it's very simple. You're missing certain documents. Sometimes it requires like a phone conversation. So all these things can also be, alleviated using Gen AI. I think there are a lot of commonalities in these use cases across the different stages RCM, which is you really need Gen AI and large language models to understand clinical chart. So that's the commonality. However, if you think about the very specific workflow for these stages, you do require some different combination of tech stack to tackle those problems. So I think no one company can do it all for the entire RCM, but it does make sense for a company to tackle a large segment of the work, for example, focus on front end misclinical versus the back end. I think at least in 2025, it's very hard to do extremely well across all the stages.
Thank you. I wanted to shift the conversation, kind of double clicking on a point that you made, which is around there's a lot of noise in the market, a lot of companies branding themselves in certain ways, but maybe not being able to execute. I don't really envy, any one of your three roles where, you're looking out the market to help you identify how to use AI for your problem areas when there's so many vendors and so many different people pitching you things. But I think for the innovators that are in the room, the 1,000-pound gorilla remains, Epic, the EHR. And for those that don't know what Epic is, Epic's, the predominant software that hospitals use to process claims and process patients. When you, Rich, as CFO, are hearing about the grandiose roadmap that Epic might have around using AI within revenue cycle, but then you're also hearing all these vendors talk to you about different ways where they can come in tomorrow and add in value. How do you think about actually adopting a point solution or a vendor or a platform in addition to what maybe Epic is already doing for you?
Well, my experience with Epic, I think it's starting to change. They tried to be everything to everybody. I think they're starting to develop some capability. But can you really be everything to everybody? So that's the thing you have to kind of think about. Where do you kind of drive that to its natural conclusion, and when do you augment? I think in terms of in this space, when you're thinking about, interoperating with payers in a meaningful way at the front end or the back end, the data about data, your ability to crawl through and look for patterns versus human beings. To me, it's kind of the size and staying power of the company, the vision of it, right? It's the openness. And I think, in the old days, it used to be like point-to-point interfaces and HL7. And so how do we get the data? And then what's your ability to influence that company? And do you have the right influencers around the table as constituents? Now, hopefully the folks that you are working with would think about the greater good and not like, I just want to do it the way I've always done it, which is a lot of, when you look at system implementations that go wrong, a lot of times I'm going to take the system and I'm going to make it look like my old system because that's what I'm used to. So it's maybe not the most granular answer, but it's a relationship. And it's really you're sizing up, what are the backers? What's your staying power? How can you influence it, and how adaptable and open is that solution? And then how, I agree it's going to take a while to do everything, but the data problem is very much similar. When you think about coding and CDI and acuity, if you have structured data in your problem list, why do we have CDI programs and say, well, if somebody had diabetes 3 months ago, or COPD 3 months ago, or hypertension, they probably still have it. Why are we having people combing through and say, hey, this might be related? It should come up. Almost like compliance will say you can't prompt, but like it's safety. This is their problem list. These are their chronic conditions. These are their allergies. These are the drugs they're on. And this is the recent results. That should just be table stakes versus having to answer queries and things like that. And then you have to get that data on a claim in order to get the DXCG score and your capitation right, or your HCC score. The data is there. It's just multiple applications of the same data. And I think if you get the right technology company that can think about the data and its different applications, I think you have some breakthroughs. That's my opinion.
Rich, really quickly on the data part. It's interesting you brought up the structured data part, which is very relevant until about 2 years ago, because you're absolutely right. Before the rise of large language model, in healthcare, if it's not structured data, you can't do anything about it. And doctors are definitely the ones to be blamed. Oftentimes,
Copy and paste.
we need copy and paste terrible. We like typing, well, also bad. Yeah. So if people like me did not input structured data to begin with, there's nothing to analyze, right? So I think that's always been why classical machine learning didn't work, RPA didn't work. But with the rise of large language model, that is no longer a problem. So I can have pretty terrible note. It will still understand what I'm talking about. So that really changed everything.
I agree. If it's structured, you're probably starting a little ahead, but you can crawl through the data and structure it, right? Yep. So I agree with you.
Charlene, I wanted to ask you about a big topic that we're actively thinking through, and I know many in the market are, which is kind of the AI integration with existing workforce that you have. There's a lot of companies out there that'll say that they'll come in and automate certain things and maybe reduce like a team size, and others that will say that they'll help elevate the folks that are on a revenue cycle strategy team and make them a lot more efficient. How do you think about the next like 2 or 3 years in terms of bringing in automation and how that maps to what your team's already doing?
Yeah, so I agree with you, and I appreciate your question. You had asked about how do we navigate all of the vendors and technology partners out there who come to us. And I remember before the pandemic, we were receiving solicitations probably 5 or 6 a week, and it's really, really challenging on our side. We're excited because we need industry partners. We need the technology. We need to partner, and because we can't do it alone with the tools that we have. But it's very laborious to sift through and find who has something that works really well. And I think the lead time for us to test those kinds of things and to understand what exactly the product is going to do for us is really challenging. It can be really frustrating. So I think if we can figure out how to expedite that and understand what exactly are we getting, and you'll probably hear from us for the partners, the technology partners out there who are knocking on our doors. It's hard for us to understand sometimes what the value is going to bring. So it's a lot of back and forth. There's demos, there's conversations. The most frustrating part for us is to hear, we're going to do this, we're going to eliminate, and when you go to our CFOs and you say, we're going to eliminate $50 million and your costs, like, then you come to us and, okay, let's sift through it. So I think presenting the value to us and then understanding how quickly we can perhaps test the solution is where we need to be.
Alvin, anything you'd add to that?
I think you asked a couple of questions. Which one do you want me to focus on?
What do you want to answer?
Whatever Akash thinks is interesting.
I was mostly interested on like the integration of AI with a workforce and how you think about bringing in AI to make your workforce better versus maybe a labor displacement type approach.
Yeah, I mean, on a philosophical level, like whenever we have a new technology like internet or cars or AI, people always think about, oh, like, are we going to eliminate jobs? I think broadly speaking, in the long run, that is not an issue because we're going to create so many new jobs and opportunities. In the short run, what I'm seeing, well, at least specifically in the RCM space, is that there's usually a labor shortage. And also there's so much to do in RCM that I think by augmenting the existing workforce, you're simply catching up. So in this very specific application, I don't think we're going to see massive job loss, and there are plenty of things to do within the AMC or integrated health system. So I'm sure there's a way to relocate and redistribute the labor. I'm not that concerned. And then another thing that I think will be an interesting thought exercise, which is when you are interacting with an AI vendor and you need to bring this proposal back to like the CFO, like Rich, which message resonates more? Is it cost cutting or is it revenue generation? I'll probably let Rich answer that question, but the good news about, I think, Gen AI application RCM is it's not that difficult to show increase in revenue. So in claims denial, right? You have a claim that's denied, that's literally lost dollar. If you can show that now you're handling denials better, that's a direct increase in revenue. Similarly, in CDI autonomous coding, if you code appropriately, usually it's an upcode in the legal sense, right? So I do think it's a relatively low-hanging fruit, so to speak, that I think that's why I'm so bullish on applying Gen AI in RCM, because it just makes sense in so many sense of that word.
Can I add something
Please.
else? So I think the question, and I'm going to expand a little bit on what Alvin was saying, is denials have been increasing. We've been seeing a tremendous growth in what we call initial denial. So the payers are just saying, nope, denied, not medically necessary. The patient should not have been an inpatient, or whatever, no authorization, whatever the denial is. I would love if instead of each time we get a denial and opening it up like it's the first time we're looking at one of these, if AI could prompt my analysts who are going to work that denial, appeal them, review it, for AI to say, here's what happened the last time a claim denied that looks sort of like this one, and helping us to say, maybe you can do this. This had a high turnover rate versus let me go through the notes and it taking forever to write an appeal letter and understand what exactly should be put in the justification for overturning it.
Yeah, I think that goes back to the analogy that Rich made earlier, which is at any given moment, you have a fairly large backlog of AR. And the next day you have a dumpster truck of new claims that come in. And how do you, attack the new claims coming in versus fighting denials? I get the time that we have about 5 minutes left. So I'll ask one last question, which is maybe starting with Rich. When you think about the next 2 to 3 years and think about the automation and AI roadmap that your organization has, how do we take that analogy that you shared with the dumpster truck and make revenue cycle much more kind of preventative and more offensive as opposed to always being death by 1,000 paper cuts?
I think a lot of it's been said. Maybe I'll say, like, where do you start? I think, when I look at revenue cycle partner, we have this massive problem, and we're thinking about kind of standard approaches for this type of denial. Why should everyone have variation in approach, and you're not going to have variation in outcome? So can a machine guide you? Get a use case, get a couple of use cases, work with a vendor, and say, this is what I'm going to do, and this is the ROI. Go do it, repeat. Show the ROI. Show me that maybe it's a big payer, maybe it's Medicare, maybe it's a couple of payers, maybe it's Blue Cross or Anthem, the same company, and this is how pervasive it is. And then show me the technology that you're going to deploy. Show me how you're going to measure it. Let's all agree on that. Go. Then get a W, then win again. And then work with a vendor that will do like agile kind of development with you and say, look, we're going to build out the pixels in the picture, but we're going to focus and do a Pareto on these are the things that we're going to move first, and show me that, and then repeat. So it's a big mountain, but I think it's all those things. It's the way we interoperate with payers and the contractual terms around that. It's building the common Rosetta Stone around payers. It's being able to crawl through, because really receivables management is really an operation. It's financial, but it's operations management. You're trying to produce a claim, a widget to payer specs so it can get paid. And you're moving them down the conveyor belt, and you have certain defects before they go out. So what's my the analogy in a payer world is auto adjudicate. Well, what's my clean claim rate? Doesn't touch any queues. And how do I engineer that? And then how does it come back? So it's really building that information and the logic, and some of it's ingesting rules. But I think you got to lay it out a roadmap and say, where's the biggest value, and just start to incrementally. But I think we should have a point of view is you should look at the data common in terms of how I analyze the data, but then how do I ingest it and work it? Because I'm working on those types of problems. They're not connected right now. So I'll stop there and let the others try to answer.
Yeah, I like the advice that you shared, which is if you lay a brick every day, sooner or later you'll have a house, and start with one use case and expand from there.
Yeah.
Charlene?
I would say that I would love to use some of the discrete data that we have and is available to us to translate what exactly at a high level is happening. I have a lot of people looking at the data, working accounts, doing follow-up, but I don't have enough analytical support to say, this is the why. I can see where my over 90 is growing. I can see these denial codes coming in, but why? And what do I do about it? I have a great partner with my contracting officer, and I work well with our group who does our net revenue valuation. But translating what's going on with all of this data is really difficult.
Thanks.
I like to make a 5-year and 10-year prediction. So my 5-year prediction is that in 5 years, if you look across the different segments of RCM, it will be dominated by third-party companies. You have few dominant players for front end, a few dominant players for mid-cycle, and a few dominant players for back end. And the reason why I say that is, if you understand how difficult it is from an AI perspective to do this well, I don't think provider organization will be able to build something good enough. The 800-pound gorilla is Epic or Cerner or whatnot. They will say they try to do it, but I just don't think they either have the technical team or just corporate focus to deliver a good enough product to get it done. And a good parallel example is when Microsoft Teams and Google Meets came out, everyone said Zoom is going to go out of business. I mean, yes, they lost, market share, but they're still the market leader right now and then using Gen AI to do our CM is infinitely more complicated than virtual meetings. And also, not only you need to have a good product, you also need a team that deploy really fast, knows how to do pilots well, and iterate with your client quickly to get a point that everyone's happy. So I just don't think it's in the culture of Epic and Cerner and big EHL company to pull that off. So that's prediction for 5 years. In 10 years, I do imagine a world where you have RCM that's AI-centric. What does that mean? Right now, we run RCM using humans, and we augment humans using AI wherever it makes sense. With the rise of AI agent, meaning these programs can tell you what the weather will be tomorrow, but also it can physically do things for you. I can imagine a world where your RCM will be run by a bunch of AI agents, then you have human in loop to just coordinate what that looks like on a macro level. I think that's what's going to happen in 10 years, or at least that makes sense to me.
Rich, you were going to say something?
Well, I think that could happen. I also think technology could prevent that from happening. Because the problems are similar. They're just nuanced by market and by payer. So I think, we're going to have to look at, you've got this book of receivables. Some of it's old and it's been denied. But if you could think about a data engine that could crawl through that and put it in like buckets. When you think about how you work your AR, how you work your denials, you typically say, below these balances, I outsource it, whatever, and stratify the AR and get machines to work this, people to work that. It's possible that you might be able to do that. But I agree that an average healthcare system, even the big ones, are not going to be able to do this on their own. They have to partner with folks who can do it. So, but if you can't find that technology, and that's the kind of the dilemma within revenue cycle, is you've got a bunch of what I'll call one-trick ponies. I deal with this MSP issue for Medicare, and I deal with this, and then you all of a sudden you have like so many vendor relationships and point-to-point data, you just can't manage it. So, how can you start to think about a vendor that could start to kind of horizontally and vertically help you in that space? If that doesn't happen, I would agree with you. You're probably going to look at aggregation points and leverage. I have some good experience with outsourced vendors, and I have some really bad experiences with outsourced vendors. But most of the time, it's how you manage them. And if you're not managing them like you manage your employees, that's typically the most common problem. But I think it's an incredibly complicated job. I think it's probably the most difficult job in finance, without a doubt. And trying to make sense of all that data, is the challenge, and that's what you need your help, and we all need the help.
Rich, Charlene, Alvin, thank you so much for joining us tonight and sharing your experience with us. We'll open it up for some questions.
As you guys mentioned, it's a really interesting time in the market right now where there's the adoption curve it seems to be picking up, pretty massive steam, even from the clinical side. Open evidence is in, the news headlines, a lot of clinical adoption. The one thing that constantly comes up on our conversations, both with health systems and provider groups, is around the budgetary restrictions and like what is being opened up either through, in your world, kind of like the CIO budget, and what can be kind of opened up in like a off-cycle budget, or if it's cost reduction or if it's revenue acceleration. How do you all each, kind of think about it across your organizations, and how would you kind of advise? We have, a bunch of customers from the physician group side and the audience. How would you guys advise, from your learnings, like how other organizations can think about it?
Well, I can start. So our budget cycle does start. It's on a yearly schedule, and we start thinking about it about 8 months out and start predicting and looking at our run rates and predicting what we're going to need. I don't mind looking at systems off cycle because it takes so long to determine if this is a right fit for us to add it into our budget. The question about cost reduction and revenue generation is you have to do both. You can't really just look at one or the other, and we focus on both of them just the same because we have to.
I agree. The budget process is like too long and onerous, and you can't predict what's going to happen. So, but it's a reality. That's why I kind of like the sprints, the agile approach. If there's a business case, I'm open to it. We're not going to cut our way to greatness. My experience, if you need something and you don't have the capability, you pay for it one way or another. So if you don't have the capability to understand how to register somebody or get a referral or an auth and what the rules are, you're going to pay for it through denials, or you're going to pay through it by hiring people or getting tools that will help you that. So to me, it's, is the investment positive in the outcome, and is the scope appropriate that I can actually, I don't want to boil the ocean, because that's, ultimately we have to, but like eat the elephant one bite at a time, as they say, and eat the right bite first. And that's, look, I'm all for that. And if we can actually turn the needle and we get a patent of wins, let's go. That's how I look at it. Thanks.
I agree with everything you guys said tonight. It's all of it just resonates completely. And Alvin, I do not, yes, Alvin, I do not want to see AI replace the doctors. It's my personal thought. Don't replace the doctors. How do you guys prioritize? So I'm with Apollo MD, and we've been partnered with Adonis for a little over 3 years now. And it's the data. There's just so much data that they've been able to kind of just bubble up to us that we didn't have previously in the format in which it is in Adonis, which is easily readable. It's kind of there. How would you prioritize where you throw your AI first? Because to your point, there's just denials and denials and denials. How do you guys prioritize that once you have the data in front of you? Because that's my struggle. Like, I want to go everywhere. I call them every day. I'm like, let's do this. Let's do that. We have to go here. We have to go there. We have to fix this. How do you guys reasonably and realistically prioritize where you want to put the effort?
Yeah. So I agree with you. I feel like I'm constantly poking at different things and trying to figure out what is going to generate the biggest value by focusing on that. Right now, I'm really, really excited and focused on insurance information. I forgot who said it. Someone here said capturing a patient's insurance information during the point of registration or during scheduling or at the time that they're arriving for a visit. We so often miss that really critical information. And then we spend a lot of time chasing it and understanding it before we get a claim out the door. And it delays the entire process. So I think that's one of our greatest opportunities across the country. It's just too hard to train everyone. And someone can go work at Amazon and for the same amount of money as the really complicated job of figuring out insurance information. So I think it's a huge opportunity.
Well, I agree. My lens is where's the speed to value? All right. So I would love to be able to ingest the rules. I had the experience when I was in Boston. Our Harvard Pilgrim was in receivership, and we needed to settle the AR. And we got into the detail. I said, well, you run an eligibility query. And it said, this woman had Harvard Pilgrim, and the spelling of the name was Bitsy, B-I-T, instead of Betsy. So the issue is that when you do an eligibility query, it uses OR logic. It's this name or the subscriber number or the date of birth. When you do the claim, it's AND logic. It has to exact match. So can a machine say, look, I'm going to give you back what you think is the right answer. I'm not going to change my medical record. So if I could get something like, what are the major hurdles in this process that a machine could help me, I'll go for it. To me, where I sit, I'd like to understand the chaos because I like to push back on the payers. And I'm not disparaging payers, but they're not saving people's lives. They've got computers and they've got actuaries and accountants and probably really good people. I mean, they're all trying to do the right thing, but it's not as consequential as losing a Yale or losing a Mass General or Johns Hopkins, which is innovating. And it's a little upside down. and there's too much friction there. So we need to figure out a way that they're part of the facilitation of paying and insuring. And I think there's a lot of kind of upscaling, upstreaming into the clinical process. How do we manage that better? And how do we get the rules? Because they talk about managing care, but it's really managing rules that prevent payment. Like when I was at BMC, we had a health plan. And so when you get a Medicaid PMPM from the state, you'll have an actuary firm will say it's within the actuarial range, meaning this PMPM, looking at the scatter of the claims data, would say it's within the range of that data, usually really low at the bottom end of the range. You have to hit maybe 40-foot putts, maybe 3 in a row, but it's within the range, right? Then what you do is you go to like a Milliman and say, what is the industry doing? Well, contiguous body parts. So then you take the claims data and you run it through and you say, I got some breathing room. It's within the actual range. I'm going to take that. Is that fair? And that's what happens. And that's a small HMO. That's going on across the country. So how do we understand the rules? And how do we understand that the way they communicate it based upon plan, employer? To me, I love the notion of like trying to understand the metadata and coming up with a common story and how the payers are doing to us. But I'm probably more analytic. Probably the more important thing is how do I get the operations working first? And then, but I think they're related. So I'll stop there.
I think in terms of where to focus, Rich talked about data. I think data has always been important. However, now with a lot of the more modern EHR, you have systems like HL7, FHIR. So I think the data pipes are relatively clear, so to speak. And Rich also talked about understanding the payers' rules. Again, really complicated, and historically, the bottleneck is for like a poor human reading through it, right? Understanding it. I think Gen AI is really going to solve most of it. With these two things in mind, now it becomes a question is, okay, like how do we find out where to focus? And what I see across the different segments of RCM, I do think that it makes more sense to focus on the mid-cycle and the back end, because front cycle, yes, it's necessary to get a prior authorization, but it's really hard to calculate ROI. You can probably figure out it takes 25% less time to get the documents in. That's pretty much it. It's hard to translate that to actual dollar sign. But what I've seen in industry is that there's a clear positive delta when it comes to coding, especially when it comes to hospital charges, not the pro fee, hugely complicated. Each delta could be $10,000. And definitely, I think the denial space is very concrete. Like you're handling X number of denials, you got Y number of dollars back. So I think it makes more sense to focus on mid-cycle and back end. Now, if you're working with any of real AI vendors, once you get the data to them, they will be able to run this analysis fairly quickly. So it will be organization dependent, depending on payer mix, depending on whether you're more like outpatients versus hospital. But I think fairly quickly, you can see from your perspective whether you're losing more money from claims denial or whether you have a huge delta in terms of upcoding appropriately that you are like leaving money on the table. I think you can do it that way. And oftentimes they'll run the analysis for you for free in the pilot. So you get your answer.
Thank you so much for joining. My name's Antoine Munfa. I work across the street at Goldman Sachs. I'm an investor in technology companies there. And, I agree with the assertions today that there's a tremendous opportunity applying AI, both in health systems generally and within RCM. I am curious to understand better, because you all seem very forward-leaning in, the space and within your organizations, which are leading academic medical centers. What skepticism do you receive internally? Like, how do you get deals approved and, testing out new technologies? What are the things that you need to see, and what are the questions that you get asked in order to approve these technologies?
I think the key thing specifically for RCM is you need to get the right people at the beginning when you do the pilot. So, for example, if you know that your CFO is going to sign the check, you say, hey, I am piloting these products. I'm going to do what kind of KPI do you want to see? Like, is it revenue uplift? Is it cost reduction? I think just have everyone agree the right KPIs to look at. It's important. And then have everyone commit that if we really hit the KPI, like 30% increase in revenue, then let's actually do it. So I think doing the pilot correctly, have the stakeholders aligned on day one is very important. Last thing you want to do is you have a team that run this pilot, you generate some metrics and you bring in the CFO and say, I don't care about these metrics or they're not good enough. And that's how time gets wasted.
Well, I guess what I would say, I think I've said it already. If I was working the revenue cycle VP, I kind of look like we're in this together. I'm going to put my neck out there and I'm going to say, I'm going to deliver this. Because look, it's not like a diagnostic piece of equipment. It's not like advancing the clinical admission. So you got to think about, I'm going to invest in this versus my core mission, which is clinical care. But it enables us to continue that mission and be able to liquidate it with an ROI. So to me, I look at it as like, we're a team. We fail, we fail. So we're going to do everything I can to make sure that happens. But that means getting the right partner, getting the right measures, having the right scope, and then delivering on that scope and going to the next one. So if you get a patent of W's, you're okay. If it's when you don't, that's when you don't. That's what credibility is. And that's why revenue cycle folks. That's how they do it. They kind of read the tea leaves. They have to influence people. They have to understand systems. They have to understand reimbursement. It's like you're at the confluence of a lot of different things. It's a complicated job. And you're dealing with the external world and you're dealing with a process that creates a claim that you don't control. So you need to think about where you're gonna make the investment and make sure you can make a return on it.
I would just add a couple of things. So we used to have a lot more flexibility with choosing products and partnering and having the dollars to fund an investment, and those dollars have sort of dried up for us. So we do have to prove the value. So we started putting performance guarantees, really explicit performance guarantees that can be measured, and adding those into our contracts because it's out of necessity. The other thing is with cybersecurity events that have been occurring, testing and understanding the data, where it's stored, the security of it has become so much of a big process that we've actually had a few missteps, and now it's just taking us a lot longer to get that security approval before we can proceed.
Other questions?
If there are no other questions, let's give our panelists another round of applause, please. Last bit of information, the bar will be open for another 20 or 25 minutes, so please indulge. Otherwise, everybody get home safe, and we'll see you next time.